Today, we are joined by a very special guest. Dr. McHenry Mac Lee, DDS, is a veteran dental clinician and educator with over 50 years of experience treating patients and teaching clinicians about temporal mandibular disorders. He co-authored the TMJ Trifecta, Solving Your Pain Puzzle, a comprehensive guide that helps people understand why chronic jaw, facial, and head pain often go unresolved and what practical steps patients can take to find relief. The book combines Dr. Lee's clinical insights with actionable steps for at-home care, guidance on avoiding common treatment pitfalls, and how to find the right provider to support long-term healing. The TMJ Trifecta speaks directly to the millions suffering from misdiagnosis and incomplete care, offering both clarity and empowerment for their pain journey.
Yes.
So how you doing today?
Well, I'm doing great. How are you doing? It's only like 80 degrees here in Texas. It's kind of like your San Diego weather, so it's nice.
Yeah, 8 degrees. It's chilly. Yeah, it's it's a little warmer than that here, but yeah. What part of Texas are you in?
I'm in South Texas. I'm a little town between Houston and Corpus Christi. Very rural,
Yeah,
very much country.
yeah. Cool. Um, so she's prepared some questions, and we can just have kind of a more informal conversation in between. But so you've written this. When did you write this book?
It came out in May of 25. It's
Nice.
but I wrote one 2 or 3 years later before that called "The Life-Robbing Pain of TMD."
Yeah.
So it's just a pamphlet and it's got diagrams. This
Okay.
book is all words because of the audio.
Okay.
So it's on audio also.
Okay. Cool. And that people can find that on just
Amazon.
Amazon. Yeah. Okay, perfect. We'll put a link up.
Worldwide. So any country that has Amazon is going to carry the book, but in English.
Okay, cool. Is it in different languages too?
No.
No. Okay, cool. So I got a couple questions here. Okay. So this is an introduction to the TMJ Trifecta. Can you share the personal and professional journey as a DDS that led you to write the TMJ Trifecta? What prompted you to create this resource?
Well, learning to do and diagnose correctly and treat correctly, TMD, TMJ, is extremely difficult because there are no resources to teach you how to do it because it's not taught in dental school. I don't know if you're aware of that or not. There are new classes beginning now that are teaching oral facial pain. That's a little bit different philosophy than I have. So when I have to have a pain patient comes to me, let's say like your brother Spencer, were to be in my care, and I did not know what to do, that's not a good thing.
Yeah.
It doesn't show much for me and for my education and how I serve my patients. So it's like, oh, what do I do with this? Because we didn't learn any of that in dental school. We only learned about infection, decay, and gum disease and how to do fillings and stuff like that. But nothing that is going to take all of this into consideration. And there are no dentists, clinicians in dental school that I know of that teach the same philosophy as that I learned. I learned my philosophy from some very powerful people that have been in dentistry for years and years and years and years and years. And I started my journey in 1977. I'd been out of dental school for 5 years and I realized that I didn't know anything. And young dentist gets out of dental school, they are so unprepared for the real world. And someone like your brother doesn't, it's a shame that the dentists in dental school are not taught. If you see these symptoms, do not try to treat them unless you really know what you're doing. And that might mean referral. And that's when I first recognized it, because at first I didn't even recognize it. And then you have to recognize it and realize you don't know what to do. And then if you don't know what to do, it's your duty as a professional to refer your patient to somebody who does know. And you just can't take their word for it. I mean, you have to interview the patient. When you went to see this specialist I sent you to, how are you feeling now? Well, if they're not getting good results, you're referring them to the wrong person. Again, this is the duty of the healthcare professional. And I also didn't like it that I had to refer to other general dentists who have the same status as me, because you have oral surgeons that are up here and orthodontics that are up here. And then you have the general dentist, and we're all supposed to be on a level playing field. But if somebody, it's a general dentist, knows no more than me, well, my ego doesn't like that, so I want to learn how to do that myself so I don't have to refer people out. So that's what started my journey. And then once I saw and was introduced to TMD at the Pankey Institute in 1977, it was just a career change for me, and I just dedicated my continuing education and resources to being a comprehensive dentist, including a TMD dentist. And you have to search far and wide to learn how to do this, but there are different schools that teach it. The ones that I went to, it still was not complete. And then I found, quote, neuromuscular dentistry, and I am on the board of the International College of Craniomandibular Orthopedics, biggest word I'll use today. But it's a collection of dentists worldwide that think the same way I think and do the same thing that's in the TMJ Trifecta book that you see behind me here. Does that answer your question to a certain
Yes, it
extent?
does. Yeah. And sorry, what was the
Okay,
summit that you went to?
I
Or
am on the board of a nonprofit organization just like yours. And the
Mhm.
name of the nonprofit is the International College of Craniomandibular Orthopedics, ICMO,
Okay.
ICCO.org. What that means is, what is the relationship with this upper jaw and this lower jaw and the joint?
Mhm.
And that is so critical to understand how everything fits together.
Mhm. Do you want to just go into that a little bit? I mean, I don't know, probably take hours to explain that, but maybe just give us a brief
Well,
overview. Probably
I
days.
kind of known for breaking things down into simplicity. Okay.
Yeah.
So do I have, a patient says, do I have TMD? Or somebody on the internet says, do I have TMD? TMJ.
Yeah.
TMJ is the two joints that we have here. TMD is the dysfunction that all of this can create.
Hmm.
Okay, so I really have to start at birth. So bear with me. If you go to undeveloped nations where they have a lot of protein, you're going to see faces that are expanded. You're going to see full faces. You're not going to see jaws that go back like this. You're not going to see crooked teeth.
Yeah.
So as Western civilization evolved and we've got all of these different foods and sugars and all the stuff that we're not supposed to be eating, as everybody knows now, it affects the airway. So the foods that we eat, the environment that we live in, and our obstruction of the nose and our a tongue tie that keeps the tongue down on the floor of the mouth. That tongue has to be up here in the palate so that it can mold the palate to be like a U. So if it's not coming in correctly, if your developing is not correctly, then the cheeks are going to, if the tongue's not up here molding, it's molding the palate, then the cheeks are going to pull in the palate like this. Well, if it pulls in the palate like this, what does it do to the teeth? They don't fit anymore. They don't fit like this. It's like a door jamb that doesn't fit, a door that doesn't fit the door jamb. So we're using that analogy. A door has hinges, and that is your joints. And then when you bite down, this is the door closing with the lower jaw hitting the upper jaw. And if this is not developed correctly, that means the door is not fitting the jamb correctly. Then the hinges on that door have to be moved to a certain extent to get the door to fit into the slot. Not any different than this. If this is deficient, up here because the palate did not expand. The jaw has to search for different places to land that's comfortable. If your gears in your car don't work correctly, what's going to happen? Things are not going to work right. It's the same thing with this. Okay. So this jaw, it's all one bone. So your two joints with it, anytime the jaw moves, the joints move along with it. So if this jaw has to go all the way back and pushing these condyles into their socket, let's just do like this. Okay, so you have your skull where the condyle fits in that little indentation in the skull. This is neutral. This is, let me turn it so I can see. This is neutral. Well, if my jaw gets pushed back, now this is compressed. And on compression, it will change the morphology of the condyles. And also this friction bone upon bone is going to take away the back part of the bone, and it looks like arthritis on a CAT scan. So then an unknowing physician, an unknowing oral surgeon, unknowing the things I just explained, we're going to say, oh, you have arthritis. It's not arthritis. It's a natural bone resorption due to compression, whether it's in the knee, whether it's in the hip and the elbow or anywhere else. You know, the thing is bone, muscles is muscles all over the body. Just because it's in the head doesn't mean it's special. It still has its own laws that it has to go by. So with the kind of dentistry that I do and the kind of dentistry that the ICMO dentists do is to find that right relationship. Okay, and say like it's right here, but when I do that, only my front teeth are hitting. There's space in the back. Well, you fill that in with plastic. So now the jaw can go into a natural arc of closure and hit something solid in the back. I don't know, you have wear on your front teeth? You have any kind of TMD signs yourself?
I mean, maybe some popping here and there, but really.
Okay, well, if you have popping, then you have a slight degree of compression within the joint complex.
Mhm.
In San Diego, you go to eat sushi,
Mhm.
you eat edamame. You don't eat edamame. When you bite down to edamame, the seed's going to pop out because of the pressure. So if you got pressure in your joint, that disc is going to pop off, not any different than an edamame seed. There's no room for it. So it gets pushed off. And everybody wants to make a big deal, big deal. Well, it's just because the joint's not in the right place and it's not in harmony. So with TMD, you've got these issues, okay?
Mhm.
You can have TMD and have healthy joints.
Mhm.
Okay, let's go back to the unhealthy joint. Okay, let's see you open your mouth. Just slightly open your mouth. Go ahead and begin to open for me. Okay, so you have just a small restriction of opening. Would I be right on that? That's
Maybe.
Yeah, but once you reach this, okay,
Yeah.
that's a restriction in the joint.
Yeah.
If the jaw deviates like so on opening,
Yeah, it does. I think it goes down this way a little bit. Yeah.
so then it's your right side that you have an issue with your joint.
I think the popping is in this one, the left side.
Okay, so
But
now
it's
but you bring up a very, very important point.
Mhm.
When you open, your jaw is deviating to the right, but you feel the popping in your left. Most people, it's not going to be that way. So how are you going to do a scientific study when everybody's different? Your brother Spencer was not like anybody in the world. His symptoms and his signs and everything else were different than other TMD patients. Where he lived and how he decided upon life is different than everybody else. And all of this plays in with the TMD patient. Let me ask you another thing: is if you remember, did Spencer breathe through his mouth, have asthma problems, nasal problems?
I know he and my sister got their adenoids out when they were really young. I never did. So I'm more of a mouth breather, but I don't really know, honestly.
Yeah, you don't know.
But
I
I,
mean, I don't expect you to know.
I
But
would be
it's little
surprised.
things like that that the pediatricians miss, the latch
Yeah.
nurses miss. It's all these things that all of these healthcare professionals that are involved in a person as they develop, they're
Yeah.
missing.
Yeah.
Would you agree with that?
Yeah. Yeah. Seems like that. Yeah.
So then he didn't develop correctly and nobody recognized it.
Yeah.
And if they did
Yeah.
recognize it, they may not have said anything to your parents because the parents would think, well, they're just trying to sell me something.
Yeah. Yeah. I think, yeah. I mean, they probably just don't be looking for it. I mean, it's kind of yeah, I think from your point of view, you would have to catch it early, I mean, this whole, I mean, really, it just sounds like it's sort of the food that we're eating, that starts it. And you hear these stories about like, yeah, people in other countries having to chew on, meat for longer periods of time, and their teeth are like perfect. And in Western countries, we have softer foods, white bread, and rice, all this stuff. And yeah, we don't form, our teeth are all kind of jumbled together because we don't, you know, our jaw doesn't form like it should.
So my analogy on that is I'm going to build a waiting room in my office if I still practice. And I'm going to have it a 10 by 10 waiting room. And I'm going to have chairs built to where they fit just perfectly and everything's neat and neat as it can be. Carpenters go in there and instead of reading 10 by 10, they build the room 9 by 9.
Yeah.
What's going to happen to the chairs? They
Fit,
have to be jumbled. They have to be put in crooked in order to all of them to fit.
Yeah.
Same thing with teeth. If the jaws don't develop correctly, upper and lower, and upper is the most important because the tongue is the one that molds everything. If the tongue cannot do its job, whether it's mouth breathing or tongue tie or whatever it is, then those chairs are going to come in crooked.
Yeah.
And that's why in the other countries, they don't come in crooked because they have room. That's the genetics. The good news is with a well-known trained dentist sees what's going on, or a pediatrician sees what's going on with a child, and they refer it to a quote airway dentist or a dentist that understands craniofacial development, then that child can have expanders. And all three of my grandkids have had expanders because it's just so obvious when you see that the development is not going as well as it should. And all three of them have had expanders. So they can put expanders, but it really needs to be before 8 or 9 years old.
How many dentists even, it's like you're trying to worry about like, I don't know, other diseases and issues and stuff. I don't think a lot of people are aware of this. But so other countries, so like in the US, I don't know what the percentage is. It seems to vary a lot, but it's like 5 to, 10 or maybe even 20%, because they don't have an accurate gauge of it, have some sort of TMD, right? In other countries, less developed countries, I mean, obviously they're probably going to have less data, but do you see, I mean, just a lower percentage of people being diagnosed with this, or is it just a lack of data?
On that. And the thing is with me and in the book, I didn't want to put anything in that book that I heard about, or I wanted to put stuff in there that I had personal experience with. So I can't really comment on that. I've never moved teeth. I've never done orthodontics, but I do understand an undeveloped maxilla. I do know where to send them so that they can get help. And if I send them to a place and I don't get what I expect from them, then I don't send them to that person anymore.
Do you think that there's anything like lifestyle wise that people can do with their kids early on to help with this, prevent this? I mean, is it like
that is what you're doing is public education. Is what I'm doing in my book.
Yeah.
Is because the people have to protect themselves.
Yeah.
People have to know, my child, that doesn't look right. Their jaw's all sunk back, even though my grandmother's jaw was sunk back. And that's not right. that's not natural for a human being. Natural for a human being is everything to be out here and be full, and the cheeks be full, and this is a third of the face, this is a third of the face, and this is a third of the face. And if that proportion's not there, even in a child, something's not right. Finding the person that knows what to do is the challenge. And the dental schools did not in my time and until recently haven't done anything about this. And I don't know what they're doing now. And I'm not associated with a dental school, so I really can't comment. But it is absolutely necessary from cradle to grave for the students to be educated on this.
Absolutely. Yeah, that's one of the main issues is there doesn't seem to be like a set curriculum, teaching, professionals about this stuff. Yeah. And there's so many, there's so many variables too. I mean, there's like the dentistry aspect, there's the, it could be arthritis. I mean, in some cases too, and in your experience, just sort of, a ballpark guess, how many cases of TMD are related to this sort of, lifestyle issue and developmental issue, as opposed to like, arthritis or some, malformation or something like that, that's sort of less related to those, sort of edge cases or
because
explain it.
A clinician and not an academic.
Yeah.
Never kept statistics. I never could delineate the things that you're asking me to do.
Yeah.
It was all on an individual basis.
Mm-hmm.
Just like on yourself, if I'm going to build an appliance and this jaw deviates to this side because this joint is not working correctly, do I want to maintain that jaw position? No, I want to try to correct it a little bit so that the bite feels harmony. But everybody is different on that. So I have to look and watch this, say, okay, now open and close. Okay, let me hear you speak. 66, 67. Oh, okay, So when somebody talks, if you were to watch me to talk from side to side, my lower teeth would be like this. So this is got a lot of room here. If you watch somebody that has a compressed joint, they're going to be talking out here. And they're going to have worn teeth that fit together. So any of you listening and watching this, if you've got worn teeth, odds are you've got compressed joints. They may not hurt. They may not cause any problems. But Mother Nature is telling me where this jaw wants to go. The teeth have nerves in them. And when they hit and that doesn't feel comfortable, we're going to send a signal to the brain. So if my upper jaw is not developed correctly, then my path of closure wants to be like this, and then the teeth start screaming, you're going to hit the front, you're going to hit the front. And so muscle memory pulls this back, so the back teeth hit. Well, that compresses the condyles. Okay, so that's not good. So I can take the right measurements and I can track you on a computer to know exactly where this jaw is going like this. And instead of letting it go back, I'm going to take the bite right here, and then I'm going to fill in all the void with plastic. Now, that's just the simple concept of a true orthopedic appliance for the mouth, which is not any different than orthopedic appliance for the feet. The concept is the same. It's all orthopedics. It's taking the stress off the system, but that's just one part of it. The other part of it is how the teeth fit in the back and what happens when they go from side to side and whether the joint. Let me ask you to do this. This is crazy, okay? But just take your fingers, lightly put them and just relax, and just lightly put your head straight up for me, please. Or not down. Now lightly close down, just till you feel one finger touch. Okay, are both touching even, or are you hitting more on one side than the other?
More pressure on this side, on the left side.
So the other side has freedom, but the other finger has freedom. to a certain extent.
More so, yeah. It's more media on this side and more pressure on this side.
But it's
Yeah,
close. Yours is
yeah.
close. A
I
lot
would
of
say so.
people can put it in there and they can take a finger and just move it back.
Really.
Or I can put my fingers in there like this and
Yeah.
in between. That's a torqued mandible. That's
Yeah.
different than posterior interferences. That's different than a deficient maxilla. That's why I call it the trifecta. Deficient maxilla, torqued mandible, and posterior interferences, whereas when you go to the side, that you have back teeth hitting, and they're not supposed to be hitting when you slide your jaw to the side. There should be a space. So it's a very complicated procedure for a dentist to learn and to be able to take care of the nuances. Okay, let's take Spencer again. He had an appliance that made him feel better for a while. Okay, so he's got all these muscles that are all spasmed up and like so, and he gets this appliance in there and it makes it feel better. Okay, so now these muscles start relaxing. Well, when they start relaxing, that causes the jaw to close different. You understand? Can you see that? Okay, so if I have a spasmic muscle right here, and I make an appliance that gives that relief, now because it's got relief, it releases more, and when it releases more, now your closure is changing again, so the appliance has to be adjusted. So my question to you: did your brother and his dentist have a relationship where they were, like a marriage, they took care of each other, and anytime they had a problem, see that? No.
I think there was a lot of, frankly, I think he might have, I mean, he was very, he was serious about his TMJ, trying to do everything he could with the little exercises and stuff like that. So I think he wore it, but he may have missed it sometimes, and especially when it stopped working as effectively. And I think it wasn't a dentist who gave it to him. I can't remember. Honestly, I don't know. But I think it may have been like a TMJ specialist who gave it to him. And I don't think they were pretty far away. They were about an hour drive away. And I don't think there was a lot of follow up and readjusting it and stuff like that. I think there was just the initial one.
Yeah. Adjustments are very, very necessary.
Yeah.
So this is a sheet of paper. I don't know how many microns thick it is, but it's more than 30 microns.
Mm-hmm.
30 microns on a patient like your brother is detected. And it's enough to put them back into pain. 30 microns.
Yeah.
So when me as an adjusting dentist as a patient, how's that orthotic feel? Oh, that feels great.
Yeah.
Next week they call back and say something's wrong with the orthotic.
Yeah.
It doesn't fit anymore.
Mm-hmm.
That's not what's happening. What's happening is that the jaw is relaxed, and if the jaw relaxed, it closes down differently by 30 microns, which is a desmute.
Yeah.
Now, for a dentist with my 50 years of experience, it takes lots of experience for a dentist to be able to find that 30 micron spot and to be able to adjust it. And you got to listen. You got to believe your patients. And, I was interested in what you said, that at first it kind of irritated you with Spencer. And because, come on, boy, get over it. And I see the same thing with my patients. They'd bring a spouse, or they'd bring a loved one, or whoever. And I watched the spouse as much as I watched the patient, because you'd see them over there, and the ones that were very, I hope you're the answer. I hope you're going to be able to take care of my loved one. You have that kind. And then you have the one like, hey, shit, here we go again, spending my money, And that's the nature of this beast. Now, how are you going to do a study on that?
It's just, it's hard because it's such a weird condition that's not really well studied. People don't really know about it. You can't see it. You just have to trust the patient. And it's not like arthritis. I mean, it is, I think it's becoming more, taken seriously, but it's not like knee pain or back pain or something like that. It's just weird. It's not taken seriously. And it is super expensive and it's out of pocket and costs thousands and tens of thousands of dollars. And, that really hurts, that's, Yeah, there's a lot of people who, spend tens of thousands or hundreds of thousands of dollars on this, and they still, don't have relief. So when you're,
Dentists that do this, that I know, that are very
Mhm.
successful, have spent hundreds of thousands of dollars on learning how to do this.
Yeah,
And the
yeah,
equipment they have, the scanning, the CT scan is
yeah,
$150,000, $180,000.
yeah,
Jaw tracking is going to be another 15, 20, $30,000. I mean, the expense is unbelievable.
mhm, yeah.
Now,
So, so the,
I do have some answers for you, though.
oh yeah,
So in May, I and some other people from ICMO in North America spoke in Japan
mm,
to the International College of Craniomandibular Orthopedics in Japan, the Tokyo
mhm,
part. And there were 14 different countries there, 14 different speakers from 14 different countries. And we're all saying exactly the same thing. So if the problems are the same, the solutions are the same. But getting the people to agree on those solutions is impossible. I can take my book and I can go to the university that I graduated in, and they would not even look at it. And the universities are supposed to be the place that are doing the studies and they're open, but that's not the reality. And that NIH roundtable, that I'm aware of, and it was Jennifer I think was a part of.
yeah,
I don't think I'd be welcome there.
right. Yeah.
You're going to be up against that with the goals that you have for your organization.
That's what I'm realizing is it's kind of a very divided world. Everybody has very strong opinions about things, and you know, it's wild. I mean, I think the only way to really combat that is with data. You know what I mean? And getting, one of our goals is to get a registry. And get, if we got 1 million people on a registry, and we're giving them like a survey to fill out, like something short, and then over time they can fill in with more information, and maybe it's all voluntary. And I don't know how exactly we're going to do this, but I think if you get enough people, the data won't lie. And then researchers and clinicians and stuff like that can use that to inform their arguments as to what the correct solutions are. But yeah, that's one thing I'm finding is like the TMJ Association has their opinion, and it seems to be like they don't push surgery, that they don't necessarily push splints. It's sort of like wait for the research. I mean, that's as far as my understanding is. And it's like, people are, they're in pain and they want some solution. And from my experience interviewing people, such as yourself and patients and stuff, it seems like there are things that you can do in the short term to relieve pain and to improve, possibly improve your situation, and, probably likely. So I think that's, I don't think necessarily any one solution is the right one, from what I'm seeing, but it's important to try things and to figure out, a correct diagnosis so that you can go to the right specialist. I mean, it's just this whole thing, but yeah, I mean, we're just trying, to meet with as many people. I mean, I'm still learning a ton, about this. I'm really new. So, but yeah,
your cause needs somebody that's neutral.
Yeah.
Which you are. Okay.
Yeah.
That's a good thing.
Yeah.
And as far as the NIH, they're only working with the dental schools and they're working with physicians, and physicians know nothing. They'll admit they know nothing.
Yeah.
They're not supposed to know anything. That's not their job.
Yeah.
ENTs, all these poor people with horrible, horrible earaches, true horrible earaches, go to the ERs, the pain is so bad. And ENT looks in there and says, your ear's fine. Let's take an MRI. You may have a tumor. Well, that puts the person in another state of fear. And all it is the condyle pushing on the nerves that are in the joint. And that's all it is. What's the answer? Bring this out. It's as simple as that. Now, there's going to be a lot more things that go to it, but that's as far as getting rid of the ear pain. That's all that has to be done. But all the stuff I told you about deficient maxilla, the other dentists treating TMD don't believe that. In fact, you have orthodontists that take 4 bicuspids out and shrink the jaw even more.
What's a bicuspid?
The bicuspid is these teeth right here.
Oh, the bicuspid. Okay.
They'll take these out and then they'll make everything straight. They make the teeth look pretty.
Right.
But it doesn't. It's too locked in. It doesn't fit.
Mm-hmm.
It's too compressed.
Yeah. So when you went to the table in Japan, so everybody would agree about the problem, but no one would agree on the solution? Or is that a general thing?
Solutions are the same. Solutions are exactly what's in that book.
Mm-hmm.
Solutions are exactly what I've been telling you about. Yeah, the solutions are there. It's that you can't get anybody in the profession to believe it.
Now, why do you think that?
There's political reasons for that. Mm-hmm. And if I got into that, I'd be pointing fingers at people I don't want to point fingers at.
Okay. Yeah. Yeah, it's crazy. I have any questions here. Mm-hmm. Okay, so how close do you think we are to establishing a standardized treatment algorithm in TMJ care team or TMJ care organization?
Until the different camps, occlusion camps, TMJ camps, whatever you want to call them, pain camps, until they start talking to one another and sitting down and being civil and get the egos out of the way, nothing's going to happen.
Yeah. Yeah, I know they wrote this, this study. I have the book over here. I don't know if you're probably familiar with it. This,
Very familiar.
You're familiar. And they have a diagnosis system in here that seems pretty good, but as a start, but apparently a lot of people don't use it. A lot of, and they have their own method for diagnosing. Do you think like legislation could help with that? Making,
No, because the legislation is going to go to the same people who wrote that. That's
right.
The national academies. They all going to go to the same source, and that is the oral facial pain specialty in the dental schools.
Yeah.
And those are the ones that won't sit. I went to their meeting. I couldn't get anybody to talk to me. I've got one past president that he and I are very civil to one another. He and I both agree that this needs to be worked out. But again, he's not a fan of my book. And the mutual agreement that he and I have is that if I were to sit with one of his pain patients and watch him go through the whole diagnosis and treatment phase, that I would learn something. And if he sat down with me, with my patients, he would learn something. And until we have that kind of understanding, it's just not going to happen. And there's no money for research, because research on diabetes comes from all of the pharmaceutical companies that could make a killing off drugs. There's no drugs in dentistry. We don't have pharmaceutical representative come visit us. We're nobodies. The dental profession is nobody when it comes to all the big powers that be. And that's another reality. Who's going to do the study? Who's going to pay for it? I live in a video town of 6,000 people. Who's going to come down and do a study on my 50 years of experience? It's not going to happen. But here's the thing, Cameron.
Yeah.
It's called heuristic training. Okay. Mm-hmm. You familiar with the word heuristic, where you learn from somebody else? You go back 12,000 years ago when they made the Clovis plane. Some dude just didn't come around and all of a sudden discover how to do that. And then somebody look at it and say, oh, yeah, I can make one of those. Mm-mm. They had to be trained, hands-on, over and over and over, hands-on. And right now, that's the only way that I can see the answers to the questions you're asking me. However, with AI,
Mhm.
with CAD/CAM technology, with the scanning of the teeth, and somebody like me training somebody, I'm not saying it's me, but somebody who knows what I know, to be able to train a dentist and a technician how to find that right spot and have the technology drill in all the adjustments, then there is an opportunity, a huge, huge opportunity. But you're going to have the jaw has, listen, this is what I know to be true. The jaw has to be in the right place and all the teeth have to be in harmony with one another as the jaw goes through its movements. Now, the AAOP, American Academy of Orofacial Pain, they're going to say the bite's not that important. I'd like to sit and watch them operate because I can't say that they're not true. I can't say that because I hadn't experienced it. But they can't say that I'm wrong because they haven't experienced what I've done. So until we sit down and say, okay, man, I want to watch you with this patient. I want to learn something here. Nothing's going to happen.
Ideal.
But having an organization like yours is putting a demand. The media changes dentistry. When I was in dental school, back up. Would you ever go to a dentist that didn't wear a mask or wear gloves? No. No, you didn't go. Okay, so I went all through 4 years of dental school, surgery, all kinds of surgery, hands and just blood everywhere, everywhere. Never, ever, ever wore gloves. Graduated in 1972. Never wore gloves when I got home. I'm third generation dentist. None of my father or grandfather wore gloves. Never. And in the 80s, here comes AIDS. Changed everything. But it wasn't the ADA that said you've got to wear gloves and you've got to wear a mask. It wasn't. You've got to sterilize your instruments. It wasn't the ADA, even though they said it. That doesn't mean these hard-headed dentists are going to listen.
Yeah.
But when the media got into it and the media said, let me tell you how to see if your dentist is sterilizing the instruments correctly, it changed dentistry overnight.
Yeah.
So your answer is media.
Yeah. I think that's true. Yeah. Yeah, that's a really good point. That's crazy. Yeah.
That's what my book's for. My book is for these poor patients who didn't have the devastation you have with your brother, but who were so miserable and spent so much money.
Yeah.
And got kicked down the road so many times because they were defenseless.
Yep.
That book gives you the education to where you can say, doctor, I'm not doing that. That doesn't even make sense.
Yeah.
What you're doing is going to compress my condyle even more than it's been compressed.
Mm-hmm.
That's when you start changing things.
Yeah. Yeah. Sort of gives patients some information and power, because they don't know, they can go to anybody, anybody can say they're a TMJ specialist and maybe to make it worse, that's, yeah.
Let me ask you this.
Yeah.
Do you know what Novocaine is?
Yeah.
I've been in practice. Well, I went to dental school in 1968. I've never, ever even seen Novocaine.
Really?
It was taken off the market before I got into dental school because it was too powerful.
Yeah.
So, but that misconception, and we named our book to TMJ Trifecta, and that's not even the name of what we're talking about. It's TMD.
Mm-hmm. I know. Yeah.
There's just so much disinformation out there. And unless you were armed with the right information, which is the purpose of that book, is to arm you with that.
Yeah.
So everybody listening to this, they need to go to Amazon and get a copy and get some, like I said, in audio also.
Yeah, absolutely. Yeah, we'll put up a link for it. Yeah, that's why we named Fight TMJ, because if you put Fight TMD, no one's going to know what you're talking about,
Oh,
or fight TMJD. It just doesn't. Yeah, but that's another symptom of the problem, is just the lack of information out there.
so I have Pam Mars, Dr. Pam Marsband in Virginia, and I have a podcast together. It's called Open Up, a TMJ Discussion. And we named
Mhm.
it TMJ because that's
Yeah,
everybody thinks it is, and it's not.
yeah, yeah, yeah. We'll put a link up for your podcast and your book, um, for so that people can buy it and follow you and everything. Um, but yeah, I think the media is, powerful way that we can, and just sort of building a community of people like yourself, really experienced, clinicians and dentists, and also patients, and just sort of, I'd like to have, some, I don't know what you call them, meetings or forums, or bringing together the specialists every year along with patients. I know that other organizations have this, but I think it's, like you're talking about, it's really important to share information. In like your ideal world, you talk about the AI, the CAD machine, and just sort of looking over each other's shoulders, as dentists and ENTs, and how would that work for you? Would it be like, somebody takes off like a week from work and just go shadows this other person? Or, I mean, that's probably not going to happen, right?
Back in my days, when we went to these continuing education courses that maybe last a week, there was no internet, there was no anything. And the only way you could learn is to go to something like this, to where you can have express your ideas and learn new things. But that's all over. The internet has
Yeah,
changed all that. And so I don't
yeah,
have any answers to it.
yeah,
And then I'm retired. I'm really enjoying retirement. And I
yeah,
want my book to be very successful from the standpoint that it's teaching somebody and making a difference.
yeah,
But I don't have any desire to jump in and to do anything. And finding somebody with that kind of energy is going to be tough.
yeah, yeah,
Energy and contacts and everything else. The
yeah,
people who are driving everything right now is the AAOP, American Academy of Oral Facial Pain.
yeah,
And I would reach out to them and try to do the same thing with them that you did with me.
yeah, yeah, yeah. We're trying to do that. Yeah, I have people trying to reach out and give me other good guests on here. I do have some other questions. I don't know how much time you have.
I'm yours.
Okay, perfect. Let me see something we haven't covered yet. So, we've already covered this a little bit, but can you talk about some misconceptions about TMJ? Maybe just the one misconception about TMJ that you think does the most harm, to patients' recovery.
Yeah. Night guards, splints.
Night guards.
Okay. So when they make a night guard or a splint, they just take impression material and run it over the tops of the teeth and have you bite down.
Mhm.
Okay. And then the lab builds a plastic piece of material. It goes on top of either the top or the bottom.
Mhm.
Okay. If it goes on the top and has a ramp on it, what that can do is push the jaw back. You see what I'm saying? If you have a ramp here, when you bite down, it's going to cause the jaw to go back. That compresses the condyles and make things worse. So when you make that kind of splint where you just send models and a bite to a lab without trying to find the right spot and the right relationship between the upper and lower jaw, all you're doing is putting a piece of plastic in already not jaws that don't fit. And so, yeah, some people you could put anything in their mouth and they can wear it. So the real enigma to TMD is that somebody has a horrible bite and has zero pain. I could show you pictures and photographs of teeth that are so broken down, and that patient has never, ever, ever had a pain. So it's the brain is involved in all of this. This would be with your brother and how sensitive he was and all these other things. I mean, it is so multifaceted. The brain is the one that deciphers pain. So if the trigeminal nerve feels like things don't fit, it's going to send a signal to the brain. And the brain can say, I think that's painful. Let me just give you some pain. Where it gives you pain, everybody's different. Some is here, some is here, some is here, here. It's very convoluted. But I'm involved with other doctors that are doing the same thing that I am. I just wrote a preface for a new book that's coming out. And it's written by a good friend dentist who does the same thing I do, a NUCA chiropractor who just specializes in C1 and C2, and a massage therapist who specializes in the hips and getting the bones and getting all of it lined up. If the hips are not in line, the neck's not in line, teeth not in line, you're going to have a miserable person. It may not hurt, but they're going to be walking like this, All this just makes common sense.
Yeah, it was kind of crazy when I learned about how the pelvic, floor is related to the jaw. It just it's crazy. You have to get everything in line. So you do recommend splints though, right? But just not any splint willy-nilly, just
they have to be very extremely precise orthotics that reposition. And the bite is taken when what I mean by bite is when they squeeze that material in between your teeth and they capture the relationship of the upper and lower jaw. Okay, that cannot be taken with teeth touching. As soon as a tooth touches, it's going to send signals to the brain and it's going to do all kinds of things. So you've got to have it where it's not touching. That's why I like the phonetics. You use phonetics and you watch somebody talk. I get a pretty good idea of where this jaw-to-jaw relationship is, and just by watching them talk. Again, it takes years and years and years of experience.
So you talked about so you use like a computer to read the. I mean, you have the. So you put the mold in, then you put in the material, but you also use a computer to read how their jaw meets, right? Is that like an X-ray or is that?
They're two different kind of computer systems.
Okay.
And one tracks the jaw, left, right, forward, back, and everything else, and it's very, very, very precise.
Yeah.
And the other is a T-scan, and a T-scan is where they bite down, and it shows which teeth, shows timing and it shows force. Very sensitive, very incredible.
Yeah.
Instrumentation. The jaw tracker is just simply a magnet that tracks the jaw. I mean, there's nothing mysterious about it. But you also can track the jaw with EMGs connected to it. Okay, which only makes sense. But to the professionals and the academic schools, they just think it's a way to sell something to the patient. That's what they think it is. And people that do what I do, they think that the other TMJ specialists are just giving out pills and sending people to get their minds examined. So we got to quit saying bad things about each other and start finding out why we're alike, how we're alike. Yeah. I'm sure they get good success. I know I got great. You know how I know I got great success is that I gave a 50% rebate on any appliance that I made.
Yeah.
So if after trials and tribulations, it didn't work, and the patient said, this thing just makes me feel bad, I'd give them half their money back. They'd have to give me the appliance back, but that just to me, proved that I stood behind my work.
Yeah.
You don't see that either, ever.
Yeah. Yeah. I think a lot of people, yeah, it seems from talking to different people, a lot of people think that other people don't care or they're just trying to make money. But I think a lot of people do have good intentions. They just may not have the right information. Um, so, so a lot of people can give you, yeah,
Let me add to that. Hmm. It's easy for me to be a TMD dentist and have dentists send me patients
yeah,
because they don't want to deal with them.
yeah,
They don't want the responsibility of Spencer,
yeah,
and you can't blame them
yeah,
because that's a TMD patient is a special patient. They've got special needs.
yeah,
They're not the problem, but
yeah,
dentists think they are. They're not the problem, but they have a problem. And they
yeah,
have a problem that the dentist doesn't know how to handle, either
yeah,
through person to person or clinically, because you've got to take both the person in mind and the clinical part. They go
yeah,
together.
yeah. They're a lot more work too, frankly, than, I mean, just fixing someone's tooth or, extracting a tooth or putting in crowns or, something like that. I mean, I would think there would be a lot more difficult and just, they probably wouldn't want to deal with it, honestly, if they're, yeah, it makes a lot of sense. So a lot of people can give these splints out, right? Who don't have the various things you've been talking about, the ENG, the tracker, and I forget what the machine is that measures the bite strength. But a lot of people can. Sorry, go ahead. The CAT scan, yeah. But a lot of people can give out splints who don't have all this, right?
Yeah, I was pretty successful. The bottom line of the question you're asking is of the trifecta, the posterior interferences and the TARC mandible can be taken care of without special equipment.
Yeah.
The kinesiograph, which is that machine with the EMGs and the jaw tracking, is what taught me about the deficient maxilla. It was proof to me that something really big is going on that's different than anything I was ever trained for, even
Yeah.
with middle school or going to the institutes that I went back 20 years ago. This is a whole new thing, wrapping your head around this deficient maxilla.
Yeah. But what I'm talking about is like you obviously know all these different factors, but there's other people who don't, and they may give somebody a splint that may not work or it could even make the problem worse. And maybe because some people are for splints, some people are against splints, it seems to me. But maybe that's the issue. Is just it's just sort of a lack of understanding and giving someone the correct splint, without the teeth touching. And then also, like we were talking about earlier, like ongoing, them coming back and readjusting the splint depending on how their muscles relax. I think that's another really important factor that may not,
Huge point. So to get to the bottom line of what you're asking, if I had a young dentist under my tutelage that wanted to learn, could I teach them to diagnose and treat TMD, TMJ without that equipment? Yes.
Yeah.
But it takes the equipment to give you that aha moment that now I understand what's going on.
Mm-hmm.
And once you understand that all the body is doing is seeking harmony,
Mm-hmm.
it's not hard to understand. Now, all the nuances, including C1, C2, and the hips, the feet, and everything else, including everything, that's where it becomes difficult.
Yeah.
But there are people, but also to answer you, there are people like my three friends that wrote the book that I got the preface to. It's not out yet. They're wanting the same thing you're wanting, the same thing I'm wanting. They want the public to be aware that we're all connected. It's all connected.
Yeah.
You don't have a building that has the top like this or like this. You have buildings that are straight like this. You don't have healthy teeth that are cracked and to the side. You have healthy teeth that are straight up and down. You don't have healthy joints that are jammed back into the fossa. It's just common sense.
Yeah. So this, these questions have to do with the future of TMJ care. What do you hope TMJ care is 5 to 10 years from now, both in medicine and patient awareness?
Ooh. Well, for the patient to be educated and understand what you and I are talking about, let me ask you this. Are you understanding what I'm saying?
More or less. I mean, there's a lot to it. Yeah.
I know.
But
I've simplified it.
yes.
But do you have a dentist that understands what I'm talking about?
Do I have a dentist? Probably not.
Yeah.
I doubt it. Yeah.
Where do you find the qualified help?
Yeah.
And today, with the insurance companies running everything, it's the medical model and dental model is completely different than I was a younger man.
Really? How has it changed?
1972, the insurance companies paid out, not in insurance, but in benefits, $1,000 to $1,500, depending on how good it was. You want to guess what it is today, what they pay today? Exactly 100% the same, $1,000 to $1,500. Nothing has changed. The only thing that's changed is that the dentists have learned to diagnose based upon what the insurance is going to pay.
That's crazy. I mean, what does $1,000 get you these days, especially with something as involved with this? I mean, that's like an initial consultation, or something like that, or maybe a splint, maybe. I mean, probably not. I mean,
no, because it's not medical, it's not dental.
Yeah.
Out there.
Yeah. So what percentage of dentists would you say have an understanding, maybe not, as good an understanding as you have, but, a basic understanding of these issues and the trifecta? Do you think it's 5%, or, I mean, just ballpark?
I'd say a lot less than that.
Really? Yeah.
Would you agree?
That's crazy. What's up?
With your experience so far, would you agree?
Well, I've only talked to people who know about TMJ so far, so I can't really speak to that. I don't really know many dentists. But based on talking to you guys, it would seem like there's a really wide lack of understanding, but I really don't know. But yeah, I mean, do you think so? Like, my dad is a lawyer, right? And he has, in order to maintain his law license, he has to, complete X amount of hours of continuing education per year. I mean, it seems to me like they could do something like that with dentistry, in order to maintain your life. I mean, I think that's reasonable.
We, especially Texas, we have demands for CE, but they turn around and make the CE easy. You can read a magazine article and send in your.
Really?
Yeah. So unless you have hands-on, it was something like TMD. I can go to a dental seminar and learn about materials and stuff like that. That's what, if you're going to learn something as complicated as this, it's got to be hands-on.
Yeah. Yeah.
You got to touch it and feel it. I can't I mean, I could pretty well take a guess that somebody has TMD or not TMD, but I couldn't do a true diagnosis without touching somebody.
Yeah. Maybe they could just learn enough to know to refer someone. I know, it seems like a problem that, Jenny's described is, and some other patients have described is, dentists will try, think they know about it, and then they'll try, or not just dentists, but other specialists too, physicians, and they'll think they know about it, and then they'll try something, and then it won't work, and then they'll just give up or refer you, or and it oftentimes will make the situation worse. So I think it's really important to prevent that. Just knowing you don't know about this problem, or you're not a specialist, and that's fine, and then having someone you can refer people to. And I think that's another issue, because it is really a specialty thing, and it probably shouldn't be handled by every dentist, but at least if they're aware of it, or know the consequences of trying something when they really don't have a really full understanding of it. They can just know to refer someone out, and I think that's important as well.
Yeah, and if a person were to read my book and just take care of themselves, it's worth writing the book.
Yeah.
Because they know what sounds right. They know, oh, this doesn't quite jive with me. I don't think I'm. And if the dentist is not caring, if the dentist doesn't spend a lot of time washing the jaw open, palpating, looking for all of these things, you're in the wrong spot. You're in the wrong spot.
Yeah, absolutely. Yeah, it's another reason for patients to buy the book and arm themselves with some information so that they can, take care of themselves. Okay, I have a couple questions here. So, what emerging clinical schools of thought are you most excited about for TMJ treatment?
Well, now you're opening a whole new. The TMJ and sleep apnea go hand in hand.
Mm-hmm.
And they should, because when that tongue doesn't develop the maxilla and doesn't develop all of this structure in here, there's a constriction not only in the joints, but there's a constriction in the throat.
Yeah.
Sleep apnea is a dangerous, dangerous condition. It is devastating on a long-term basis. It just takes away, it just picks at the immune system and everything else. And we got to have oxygen when you sleep.
Yeah.
And it's not just the oxygen. It's what happens when that throat closes up and the body's reaction to it. So cortisol is flushed all through the body. All these hormones are flushed through the body because the body thinks it's choking.
Yeah.
And then you fall asleep and you wake back up. You do this again and all night long, and the body can't recoup.
Yeah.
So so airway and TMJ have to be a big, big change in the knowledge and comprehension of the importance of both.
But you feel that that's advancing.
Yeah, they go hand in hand. I mean, you can't separate. I've got friends that only are doing airway and sleep dentistry, sleep apnea, and dentists that are doing just TMJ, and they go together.
Yeah, that's another. It's crazy how many different things are involved with this. I mean, it's just like, yeah, it's insane to try to learn about all this stuff and retain it all. And yeah. Okay. In your decades of clinical practice and teaching, how has your understanding of pain and healing evolved over time? What do you think are the next steps or things that we should work on to understand?
Everybody needs to understand. This is something I learned from my father, and he learned from his grandfather, that if you take away the obstruction of healing, the body has the capacity to heal itself. Mm-hmm. So in gum disease, if you take away the bacteria that causes gum disease and you take away all the calculus and barnacles that it lives under and teach the patient to keep the area free of pathogenic bacteria, the body's going to heal. Mm-hmm. Period. You have a broken bone, you set it, and you keep it set where it doesn't refracture, the body's going to heal. Yeah. In TMJ, they say that's not true, but that's wrong. It is true. TMJ, you put an appliance in or you change the teeth so that there is no bad trifecta and the joint's in a healthy place. the body's going to heal itself. It's unbelievable what the body can do. But you got to take away whatever is causing the problem. You know, it goes back to the old Indian saying, when are the rivers going to go down? Well, when it stops raining.
Makes sense. Yeah. It's just common sense. Yeah. Yeah. That makes sense. Okay. This is the last question. What is one thing you wish every TMJ patient could hear and truly believe?
That there is hope and that there is answers. You're not crazy. Your pain is real. Pretty simple.
Yeah.
But finding that help is very difficult. And another reason I wrote the book.
Yeah. Well, do you want to talk about anything else?
No, I think you pretty well covered it.
Okay, cool. Well, I really appreciate you coming on here. We'll put the link for the book under here on all our social media and on YouTube. So everybody who's watched this, please go buy the book, the print copy and the audio copy. And then when that next book comes out, that your friends are writing, you're writing a forward for, maybe we can, get back together and talk about that. But I think there's more that we could talk about too. So maybe, a few months down the line, we could have another meeting. I don't know if you have any time, but I've certainly enjoyed the conversation and learned a lot. But yeah, I really appreciate you coming on here and giving this information out to people.
So I want you to do me a favor.
Yes.
You're talking to some of these other dentists, especially the academics, that's going to tell you that there's no science and we can't do anything until there is a science or wrong.
Mm-hmm.
There's an answer. And I know the people that have the answers. I've had the answers myself. And that there's hope out there for the pain patients. It's just, they've got to have hope.
Yeah.
Spencer had to have hope.
Yeah, absolutely. Yeah. I mean, there is research out there. I mean, there is, some research, there's not enough research. There's obviously needs to be more research.
Okay,
but
if that were true,
yeah,
if there's research out there, then why isn't there a standard of care?
Yeah. I know what you're saying. Yeah. But there's got to be way more research. But yeah.
I've gone to a lot of classes from dentists that I didn't know what they were talking about.
Yeah.
But yet they were in the position to be the ones leading these studies.
Yeah. I know you.
Here's a sidebar that's very interesting.
Yeah.
Back in the 80s, I was teaching non-surgical periodontics, gum disease. And just clean the area of bacteria, put an antimicrobial, teach the patient, and everything will clean itself. So I was very into gum disease. That's what I was going across the nation in Canada teaching. And USA Today, all of a sudden, they had 5 different front page columns: floss or die, meaning it was all about gum disease.
Yeah.
So two reporters wrote this thing, and I got a hold of one of them and on the phone. And I said, how did this all come about? He said, well, we were in a reporters meeting. It got to be very boring. So we were walking down the halls of the hotel and saw this sign about a dental meeting, a dental convention. So we snuck into the dental convention and listened to what was going on. And there are all these professors and they're arguing about whose study was right, about the fact that there is a link between gum disease and heart disease. They didn't talk about the unbelievable story that gum disease and heart disease were linked. They were arguing about the studies. And that's academia to me, who I'm a clinician, you got to look at everything. Academia is not always the right, truthful path.
Everything. A lot of ego involved and people trying to push their study and their point of view. But yeah, you think of science as just everybody just trying to pursue the truth, whatever, and
Their
but
truth.
that's not well, yeah, their truth. In reality, it's they've taken 20 years to study their point of view, and they're heavily invested in it. And yeah, that's interesting. Okay, well, I really appreciate you coming on here again. This is really fun and informative, and we'll chop it up into clips, and we'll share it on social media. We'll post the whole thing on YouTube, and we'll put the links to your book on there, and we'll send you a little release and everything. But yeah, I appreciate you coming on a Saturday and taking time out of your day to do this. And I think it'll help some people, and they'll buy your book, and it'll just one little step further in helping patients out and getting some information out there. So I appreciate it.
That's true. One step further.
One step further. Yeah. All right.
Have a good day, sir.
You too, Mac. Thank you very much. Okay.